Okay, let's just discuss the third stage of labor. So actually there's this term AMTSL and students get confused like what is this AMTSL? They think that this is something very specific. This is just active management of third stage of labor, okay? And they specifically ask the students to confuse them that what is AMTSL, and they lose all their confidence as oh my god, what is it? It's just active management of third stage of labor. So, third stage nowadays is always actively managed. Why? If someone asks you to prevent PPH, okay, postpartum hemorrhage, the chance and risk of postpartum hemorrhage is very much reduced if you do the active management of third stage of labor. So always, as we say that the first stage of labor, is not actively managed unless, it is excessively prolonged. But the third stage is always, actively managed no matter what. So this is the alternate term that we use for third stage of labor management. Now, so what are the complications that can occur? There can be retention of placenta in this case, and there can be, uterine inversion. Okay, don't mind my handwriting. It's really nice. Okay, now the thing is that how are you going to define the third stage? We know that baby has been delivered in the second stage. Now this, starts with the, after the delivery of the baby. Okay, after delivery of the baby this starts and it ends with the placental delivery. So when all the the whole placenta is completely delivered, then we say that the third stage of labor has ended. Now, what is the significance? Basically, the thing is that we know that we have different, endometrial layers, and the decidua basalis, okay, the basal layer, the decidua basalis has a spongy layer. Okay, we know that this spongy layer acts as the cleavage plane for the separation of placenta. This is very important. They ask you when they're asking about the third stage that what is the cleavage plane, because this is the region, this is the plane where placental separation occurs, and this is something you have to identify if you are manually removing the placenta in case if it has been retained. Now, there are two methods of placental separation. They are very important because one of them plays a role in excessive postpartum bleeding. The first one is, occurs in 80% of scenarios, and this is, I don't know how to pronounce this correctly, but this is, I think, Schultz method or the Schultz's method. So this Schultz's method is also known as the central method of placental separation, and this is, it naturally occurs most commonly. And then we have the marginal method of placental separation. This marginal method is also known as the Matthew-Duncan method. Matthew-Duncan method. Okay, so why am I mentioning these two methods? Thing is, okay, let's just suppose that this is the uterus, okay, and the placenta was, let's say present in this whole region. This is the whole, the placenta. Now if this placenta separates, in the central region, what will happen is that over here it will separate and come forward. Over here blood will accumulate behind the placenta, okay, and this is known as a retroperitoneal hematoma will form, or a retroperitoneal hemorrhage will occur. Okay, and so the blood will, stay behind the placenta, and so PPH chances will be lower. It will not, seep out freely because there is a placenta in front of the, the released blood. And how will you know that the central method of placental separation has occurred? Now these two things, they occur naturally. This is not in our control whether central separation will occur or marginal will occur, though central occurs more commonly. So in this case what will happen is that the fetal side of the placenta comes out of the introitus. And how will you identify the fetal side? It is the shinier side. In layman terms, it is the shinier side and the more glazed side. So whenever, a mother delivers the baby and the placenta comes out and you see that there's a shiny side has came out, then you can say that the placenta has separated from the central method or the Schultz's method. And this is, a good thing because in this case, the chances of postpartum hemorrhage are lesser. Now, the second one was a marginal method. Let's say that this is the uterus and the placenta, it starts separating, from the margins first, from this portion first. The other portion is, intact. So when it starts from the margin, the blood will directly come out. There is nothing in front of the blood to stop it from seeping out. In the central method, there was placenta in front of the blood, because the central portion was separated, so blood was present behind placenta, so it prevented it from seeping out. But over here there is nothing, so the blood will directly come out from the marginal regions. So in this case there will be very high chances of PPH. And how will you know that marginal method or Matthew-Duncan method has occurred? The maternal side of the placenta will come out, which is basically known as the dirty side of the placenta. Is rather dirtier, it is not shiny. So these are the two methods of placenta separation. Now, we have learned about the placenta separation. Now, one more important thing is, this was basically to explain you the concept of in which type of separation PPH will occur, and you should know the names of these two methods. Now, how will you know that the placenta is has started to get separated? The first sign will be the uterus will become more globular. If the uterus was like this, it was flaccid, now it will become more globular, more in shape, more firm, more bloatable. Okay, well contracted uterus. Why will this happen? Because we know that after the delivery of the the baby, the uterus starts to contract, and the placenta is over here. Okay, so when the placenta has started to be separated, the uterus can now contract more freely and in a more better manner, so it becomes more firm and more globular and more bloatable. Okay, so this is the first sign that the uterus becomes more globular or bloatable and firm. Now, one more thing that is very important is that there is a sudden gush of blood, as I just mentioned, that as placenta separates, blood always comes out. Now, whether more blood will come out or less depends on what is the method of placental separation, whether it is marginal or central. Less blood will come out in central method of separation. Now, one more thing that happens is that I'm again going to draw the uterus. Let's say this is the hypothetical uterus, and the placenta was over here initially. Now it has separated, it has come over here. Now this portion is free of the placenta, so this portion can now contract freely. Okay, so what will happen is that the fundus is going to contract, and this will cause the uterus to rise. It will cause the uterine fundus to rise above the umbilicus. Okay, so we can say that the fundal height slightly increases till it goes above the level of umbilicus, above the level of umbilicus. And this is not happening because the uterus is becoming larger. This is happening because now the fundus is contracting more properly, so it is becoming more prominent, and it seems as if it has reached above the umbilicus. Now, one more thing that is going to happen is that you're going to see a suprapubic bulge. Always a suprapubic bulge is going to be there. Okay, and one more thing is if someone asks you what is the most definite sign, okay, the most definite sign is basically that there is a permanent lengthening of cord. Okay, the cord permanently lengthens. Okay, and how will you know? The clamp will, this is the introitus. Okay, this is the introitus, and let's say this is the cord coming out, and this is the clamp. The clamp will, permanently descend away from the introitus because the cord is lengthening, and this distance is going to increase, and this is going to increase permanently. Now, it will not increase any further. Permanently lengthening has occurred now. So these are all the 5 signs of placental separation. Okay, now just let's quickly review the signs of placental separation. Okay, these are the signs. We will discuss the order later. First of all, now there is going to be the uterus was like this initially when the placenta was attached. Now it is going to become like this. Okay, more globular, more firm, more bloatable. Okay, the other sign is that there is going to be gush of blood. As I mentioned, that as the placenta separated, all of course blood is going to seep out. So sudden gush of blood. Next is the fundal height seems to be increased. It seems like the uterus has reached above the level of umbilicus suddenly. This is happening only because fundus is contracting well now. Uterus is not actually, the height is not actually increasing. It seems as if because it is contracting more properly. And then there is going to be a suprapubic bulge. Okay, this is also very important. A suprapubic bulge. And then permanent lengthening of cord. Now permanent, don't mind my writing. Permanent lengthening of cord is the most definite sign. Writing, I'm saying that again, focus on the audio. So these uterotonics, we give them immediately after delivery of the baby. Okay, baby is delivered suddenly, and then you start using the uterotonics. Now, mostly we prefer syntocinon or oxytocin, 10 units IM. Now the thing is that this syntocinon, always remember that this is the ABC of OBS, that it is always stored in a fridge at 2 to 8 degrees centigrade. So in a village, or in an area where you don't have a fridge, so you are not going to use syntocinon. In that case, you can use oral misoprostol, which is not which is less safe as compared to oxytocin, but you have to use it if you don't have a fridge in the area. So misoprostol is used, and this misoprostol is stored at room temperature. Okay, so that's why we prefer it when we don't have cooling facilities. Then we can also use Methargen, which is very dangerous. Okay, it is contraindicated in case of cardiovascular issues, and it can also, it's very dangerous because this can also lead to retention of placenta. Okay, so this Methargen has a risk of placental retention. Always remember that. Okay, so you were actively managing this stage, instead you gave rise to another problem. You are the culprit in this case. Okay, so use it very carefully. Now the second component is delayed cord clamping. Now why are you delaying the cord clamping? CC for cord clamping, always clamp it from after between 1 to 3 minutes after delivery. Okay, not 1 minute before delivery. So never do it in less than 1 minute. Never clamp it after 1 minute. You can clamp it. Why? Because extra 80 milliliter of blood reaches the fetus. So this is good. 50 milligram of elemental iron. This is just for knowledge that why are we delaying the cord clamping. But there are certain cases when you have to do early cord clamping, the opposite. What are those? Those are an exception. We will discuss them later. But just, first remember that uterotonics are used, which 3 uterotonics options we have, and then we are going to go for delayed cord clamping. Now, the third is very important. This can be asked in MCQs. This name is not written in 10 teachers. Okay. Control cord traction. You are going to now remove the placenta by, applying tension to the cord and slightly pulling it out. And now the method which we use is called, I'm writing it properly, modified Brandt Andrews method. This is very important. This method's name is not mentioned in 10 teachers, and it was given in MCQs. This was the correct option, and this can also be asked in Viva. This can also be asked as an essay question. These AMTSL can be asked. So always remember this modified Brandt Andrews method. I will suggest you to watch a separate video on how this method is actually done, in a proper, video explaining it. So what you do is that you take your one hand and you put it on the abdomen. Okay, let's say this is the abdomen. You put your hand on the abdomen. Okay, why do you keep it above pubic symphysis, not on the abdomen, just slightly above the pubic symphysis, so that you can now push it backward, so that the uterus is not inverted. You push it, and now with the other hand you pull the cord out. Okay, so if you pull the cord out without applying pressure backwards, then when you're going to pull it out, you are also going to invert the uterus out. So in order to prevent inversion of uterus, you are going to first push to keep the uterus in its place, and also to feel for the contractions. Okay, only do control cord traction, CCT. This is a new abbreviation I'm using. A control cord traction, only do it when the uterus is contracting. Okay, and how will you know that the uterus is contracting? You're going to feel for the uterine contraction with your hand that is placed over the pubic symphysis. Okay, always remember this. And then control, you are going to apply, stretch the cord in a very controlled manner. Don't pull it, and you are going to invert the whole uterus, and a lot of problems can occur. So this is the third component. This is the most important one, modified Brandt Andrews method. Now the fourth one is basically you have to do assessment of the uterine tone. Why? Uterine tone assessment must be done. Intermittent uterine tone assessment must be done, because to always be on an outlook of for atony, because atony is the most common cause of PPH. So we have to do intermittent uterine tone assessment, so that we can see that what if atony has occurred. So to rule out atony, we are doing this uterine tone assessment again and again throughout the whole process. Okay, so these are the whole steps. Now I'm going to ask you a question. Okay, so this question is already marked. I don't know. Oh, you have already seen the answer here. All of the drugs are used for prevention of PPH except which drugs? Oxytocin, misoprostol, mifepristone, and methargen. Oxytocin is used, yes, we just studied it. Misoprostol is used, yes, when you don't have a fridge, because this can be used at room temperature. Mifepristone, no, I did not mention this drug. Methargen, yes, this is used, but this has a very high chance of retention of placenta. So which one is not used? Mifepristone. So mifepristone cannot be used. So this is the wrong option. So we have to mark it now. When are you going to say that a modified brand induced method has failed and you are unable to deliver the placenta? Within 30 minutes. Okay, if within 30 minutes it has failed to occur, then you say that this is a case of retention of placenta, and retained placenta is a a separate complication.